Record. Okay.
Okay, now it's recording.
Yeah.
You ready?
And scene.
All right. Hi, everybody. Sabrina and Janine here today. So we're going to talk about adhesive capsulitis. So the learning objectives for adhesive capsulitis are describe the mechanism of injury and the pathology, describe the progression of adhesive capsulitis, describe the capsular pattern and functional limitations that are associated with these pathology.
And also describe the treatment strategies, acute through recovery for adhesive capsulitis, and describe compensatory movement patterns common to adhesive capsulitis.
Okay, so pathology and etiology. So adhesive capsulitis is also known as frozen shoulder and is a condition that is associated with shoulder pain, inflammation, reduction of the joint cavity and stiffness, and is also the main characteristic of these pathologies, the decrease in range of motion of the shoulder in multiple directions, which can be both voluntary, so through active range of motion, as well as by others. So even by passive range of motion, there is a significant limitation of motion. It is onset, and the onset is gradual over weeks or months, and is more common in women and age between 40 and 60 years old. And because of these limited restricted motion and atrophy and a lot of time immobilization, we can commonly see muscle loss around the shoulder. So that's really common too. Mechanism of injury. So it's for this condition is generally accepted to have both inflammatory and fibrotic components. So inflammatory because of the pain and inflammation of the joint capsule, and fibrotic components because of the hardening of the shoulder joint capsule, which is the central process of this disease, and is a result of adhesion and scar tissue around the joint, and a significant reduction of the synovial fluid inside the shoulder joint. And because of this reduction of the synovial fluid, we start to see incorrect lubrication between the head of the humerus and the glenohumeral fossa of the scapula during movements, which is going to be affecting the arthrokinematics of the joint. Is going to increase friction, increase inflammation, and increase fibrosynovial adhesion. So it's kind of a cat that by his own tail. And also, it has been found that during the painful stage, so during the initial state of inflammation of stage 1, there is a significant amount of inflammatory cytokines, which are, we know they're typical for inflammatory processes. And during the later stages, we see a lot of dense collagen tissue in the joint capsule. So adhesive capsulitis progression. So it's described in 3 phases. We have the acute freezing painful phase, which is the first one. And as I said, is a gradual onset of shoulder pain. And this pain can be felt at rest as sharp pain, as well as during night with sleep interruptions. And then the second stage, stage is like adhesive frozen stiffening phase, where we start to see like the pain starts to subside. But even if the pain decreases, we see a progressive loss of glenohumeral joint motion in the capsular pattern that are usually allowed by the joint. And pain is felt only at extreme, like when the movement becomes extreme. And these usually occurs around 4 months. It can last up to 12 months, a year. And the last stage is resolution, and is spontaneous progressive improvement in functional range of motion. There has been a lot of sort of contradicting studies about this. Some studies said that there is this improvement in functional range of motion, whereas other study showed the severely restricted motion and profound loss of functions that remain due to the scar formation in the joint capsule, and these can last up to 3 years. So frozen shoulder can be primary or secondary. Primary, it's idiopathic, so it's the cause of these pathology is kind of unknown. So occurs with not known reason and is the most common lesion, versus secondary, where it develops after an injury, prolonged immobilization, after proximal humeral fracture, as Jill said, and surgery of the shoulder. So treatment for adhesive capsulitis, so for the acute phase, it's more about range of motion and controlling pain. So we have manual therapy techniques of the shoulder joint to restore range of motion and function. We're always moving within the available pain-free motion to actually allow lubrication of the joint and relaxation of muscle guarding of the glenohumeral joint, cervical area, and scapulothoracic muscle. So range of motion can be active, passive, or assist range of motion as long as they are pain-free. And they, as I said, stimulate removal of metabolic waste, increase of blood flow, and assist in reduction of edema. We can use the pulleys in a slow and controlled manner. And as being found that muscle releases, acupuncture, dry needling, and kinesiology taping are used as pain relief, and they can assist these painful inflammation phase. And modalities, so hot and ice packs, they're highly used during this stage, especially the moist heat is used in conjunction with stretching, and that can help muscle extensibility and range of motion by reducing kind of the stiffness of the muscle around the joint. Ultrasound and laser therapy, and also NSAIDs, analgesics, and intra-articular steroids injection can provide some pain relief.
And so for the subacute stage, also known as the frozen stage, this is when we start to get more of an increase in range of motion in the glenohumeral and scapula. And we can just keep progressing on the wand exercises. We can also do hand slides on a table. Stretching is really important, manual stretching. There's also some really good self-stretching in KNC to use for frozen shoulder. Strengthening exercises, it's good to focus on multi-directional isometric contractions, and then we want to progress to light resistance dynamic exercises within available range. Modalities to increase joint capsule and soft tissue mobility include moist heat, which is good to use before treatment, and ice pack post-treatment, as well as ultrasound. And then here's some example of some self-mobilization techniques. You can find them in K and C, but there's a caudal glide of the humerus, interior glide, and the posterior glide of the humerus. We can also perform as PTAs passive joint mobilizations. I don't think we learned a lot about this yet, but we use them for grade 3 sustained or grade 3 and 4 oscillations. And with this, we want to focus on restricted capsular tissue at the end of available range of motion. And there's also a technique called end of range, which is also found in KNC, glenohumeral elevation progression and glenohumeral external rotation progressions. More examples of strengthening exercises. It's important to strengthen the rotator cuff. So we could do this by using closed chain isometrics with elbow at 90 and arm at side like this man's doing right here. We can do isometrics with internal and external rotation, abduction, and forward elevation, and then slowly progress to adding light isotonic resistance exercises. This can be done with a TheraBand, like this picture here, or with dumbbells. And then we want to strengthen the scapular stabilizers in closed chain. We want to do exercises such as scapular retraction and protraction, depression, and shoulder shrugs. And then progress to open chain exercises and emphasize deltoid strengthening. And here's some more examples, scapular retraction in the posterior capsule stretch, as well as you can isometrically do shoulder external rotation with your opposite hand. And then the recovery stage, called the thawing stage, stretching and strengthening are progressed as the joint tissue tolerates. So we want to progress to submaximal to maximal resistance, resisted, concentric, eccentric, weight-bearing, and non-weight-bearing exercises. We want to have multi-directional dynamic movements within exercise. We want to emphasize movements that stimulate functional activities, such as overhead loading. And then we want to progress the complexity and speed of controlled movements and promote endurance in the prime movers and stabilizing muscles. And it's also important to emphasize proprioception. We can do this with balance boards, slide boards, plyo ball. There's a good example right here of a woman in closed chain. Special considerations. We want to reassess mobilization techniques if a patient is experiencing pain or they're getting decreased range of motion after we perform the exercise or the mobilization technique. We can do this by restricting the joint to a safer range of motion, correct the faulty movements, and alter intensity, frequency, and or duration of the technique. We also want to inhibit muscle spasm and correct faulty movements because muscle spasms can lead to faulty deltoid rotator cuff mechanism as well as an altered scapulohumeral rhythm. And there's a thing called mobilization with movement. It's a technique to help correct muscle spasms, and it can help improve joint tracking. And we also want to emphasize trunk stability because active cervical retraction and thoracic extension are especially important for shoulder function. And okay, I stopped the video.
I think it's still recording actually.
Am I? Oh.
You turn off your video.
I feel like an old mom.